Okay. Term 3, week 1, all about endocrine disorders. Thyroid was only the clinical case. Common endocrine disorders: hypothalamic pituitary thyroid axis, the physiology, the hormones. I put up this picture, quite a summary there. All the hormones, and know the hypothalamic pituitary axis and pituitary to endocrine gland axis, the feedback loop. And when you say tertiary endocrine disorder, secondary and primary, what does it mean? And the commonest diseases in the list: thyroid, Graves, Hashimoto's, multinodular goiter and cancer. Only 4 major conditions. Cancer, that too important, is only papillary carcinoma. Adrenal glands, Cushing's, Addison's, Pheochromocytoma, adenoma, carcinoma, all minor issues. Probably Cushing's is little more minor, no, less minor, but you all know very well. Hypothyroid, parathyroid, hypo and hyperparathyroidism. Hypothalamus, SIADH, diabetes insipidus. They are all clinically important, but pathology probably minor. Anterior pituitary, lot of minor: diabetes insipidus, atrophy, hyperfunction. Anterior pituitary, I have put this wrong, isn't it? It's not insipidus, that's posterior pituitary. Okay, just the adenomas, commonest is adenomas, hyperplasia, and then hypoplasia, hypopituitarism. All other things we cover later, diabetes, ovaries, and other things later. Okay, hyperthyroidism, hypothyroidism, just a summary of features. You should be able to at least 4 or 5 with pathogenesis explanation. In a hyperthyroidism, that is Graves' disease commonest, gland is hypervascular, plenty of blood vessels, plenty of follicles, more secretion, but the secretion is being absorbed by vacuolation. So, lot of activity, red gland. Hypothyroidism, Hashimoto's disease is total chronic inflammation. Thyroid gland converted into, looks like lymph node, microscopically also. Plenty of lymphocytes, lymphoid follicles, no activity, very small atrophic follicles. So, that is the microscopy there. Big follicles with vacuolation of this colloid. Hashimoto's, plenty of inflammatory cells, small atrophic follicles and lymphoid follicles. Both are autoimmune, the difference is in the target. Multinodular goiter, endemic. Understand the pathogenesis and note that clinically most of these patients are normal by thyroid function. Although the thyroid looks very abnormal, function is usually normal, not necessarily all the time, but usually normal. The thyroid gland is compensating for all the lack of iodine by hyperplasia. Carcinoma of the thyroid, there are many types, but commonest is the only 2, papillary and follicular. Papillary 60 to 70%, spreads to lymphatic nodes, usually good prognosis, usually small tumors. Follicular is younger age, more age, papillary is the youngest age, spreads by bloodstream. This is one carcinoma unlike other carcinomas, it spread by bloodstream to bone. It is good prognosis only with therapy, otherwise it is an aggressive tumor. The only microscopy I expect you to remember is papillary, wherein you will see foldings, papillary foldings and Samoma body. It is a calcification, microscopic calcification. Grossly, tumor is papillary. That is all for the major learning. Minor, Posterior pituitary I am starting with syndrome of inappropriate ADH secretion, too much ADH, water intoxication, diabetes insipidus, not T, D, too little ADH, dehydration, high serum sodium, low urine osmolality. I have just put the summary features, clinical features please write down. Adrenal glands, cortex, medulla. The commonest pathology is medullary pheochromocytoma, enlargement producing a nodular or diffuse hyperplasia. Conn's syndrome, congenital adrenal hyperplasia, that is 21 hydroxylase deficiency. Pheochromocytoma, the tumor, uniform cells, all endocrine tumors look similar. Even the carcinomas, benign tumors, they are all just uniform cells with capillaries in between, just like endocrine glands, and it is only the infiltration and the size makes it benign to malignant. So, easy to remember. Okay. Waterhouse-Friderichsen syndrome, sudden hyperplasia, hyperstimulation of adrenal gland, medulla, leading to hemorrhage, septicemias. Addison's disease, atrophy of the adrenal gland, hyperpigmentation, lethargy, hypotension, skin pigmentation, and in developing countries commonest cause is tuberculosis. Multiple endocrine neoplasia syndrome, MEN syndrome, type 1, type 2. Just note the components of each. Term 3, week 2, diabetes, all about diabetes, very important, but good thing is you all know very well. Difference between type 1, type 2, complications, pathogenesis. How does a clinical scenario appear if it is type 2, type 1? Modi, Lada, our clinicians' favorite in the previous year exams. A lot of questions asked on this, and CPC case and even the exam cases have been built to confuse you between either Modi or Lada with type 1 or type 2. So, questions different types. What is the mechanism of complications? Important question we ask. So, 3 major pathways you should mention. Deposition of advanced glycosylation end products, blood vessel damage, activated protein kinase C, and polyols. Where it comes, what tissues. Infections are common, but the question asked is why, and never write hyperglycemia. You will get a negative marks from me, and if I still get angry, I will take out some other marks. Hyperglycemia is not the reason for infections. Okay. Foot ulcer, retinopathy, proliferative retinopathy, non-proliferative retinopathy. Again, all these things we are asking pathogenesis. Neuropathy, angiopathy. What is the difference between microangiopathy, macroangiopathy? What is the name for microangiopathy? No? What is the name for microangiopathy in diabetes? Hyaline arteriolosclerosis. What is the macroangiopathy? Atherosclerosis. You all know, but don't want to open. I will write in the exam. So, diabetic nephropathy, the nodular glomerulosclerosis, Kimmel-Stell-Wilson lesion. Why it is nodular? Papillary necrosis. Why papillary necrosis? Pyelonephritis. Why? Chronic renal failure. GLUT4 and insulin acts on only these 3 tissues, and there is a JCU research on this. and incretins is the new theory and the new medication. Okay, so most of the diabetics now are on anti-incretin or incretin prolonging drugs, anti-GLP, DPP4 inhibitors. So just I have given a brief, but have a good read about, because this totally changes the understanding of diabetes from what we knew before to now. Peripheral resistance is no more sustained by the research. Although we still ask that, you still write type 2 is peripheral resistance, but this new finding has totally changed that. So insulin resistance, diabetes classification, you all know. Now type 1 diabetes, genetic predisposition, environmental, query in viral infection, autoimmune insulitis, inflammation in the islets of Langerhans, beta cell destruction, insulin deficiency, secondary diabetes. Okay, type 1. Type 1 course, sudden presentation. When the beta cells are decreasing, it does not produce any clinical features. Sudden appearance following a upper respiratory infection usually. Whereas type 2, genetic predisposition, we do not know, obesity, lifestyle factors, added to that insulin resistance, beta cell dysfunction, relative insulin deficiency. Again you can write the incretin theory, abnormalities of incretin function leading to diabetes, total exhaustion leading to insulin dependent, clinically gradually increasing over the years, unlike type 1. So type 1, type 2, microscopic difference. Type 1 has inflammation, destruction of beta cells. Type 2 is perfectly normal except till the when the end stage there is islet hyalinization. Remember, what is deposited is not age, what is deposited is different. Retinopathy, nephropathy, papillary necrosis, arteriolosclerosis and atherosclerosis, neuropathy, cataract due to polyol. So I just put that picture, how leakage of glucose combining with the basement membrane protein, age deposition, narrowing, ischemia and all the features of diabetes. Week 3, starting with the big system, central nervous, with head injury and brain injury, stroke. Pathophysiology of cerebrovascular accidents. Briefly, it was a review of hypertension, but we moved it to the last CPC. I will skip all this because it is just stroke and head injury the major. Always remember the major functions of the frontal lobe, parietal lobe, temporal lobe and different functions, because in the exam we give clinical history suggestive of which area. So your diagnosis depends on that. Berry aneurysm, I wanted to show the picture but I forgot. It was a scanned picture of few exam papers from last few years, where students did not know A, B, C, D of anatomy, and we all had a big laugh, although we were crying inside. Many students had written a big circle with 1 plus, and that was circle of Willis. They did write anterior posterior, but it was just one big circle and 2 plus lines, and somebody writing 2 lines and 2 lines this way. Horrible. And we take it seriously, anatomy, although we laugh, the students gets a 0. Know the anatomy, many times we ask along with pathology. So the common sites, the pathogenesis, deficiency, congenital deficiency, berry aneurysm, but causing damage in patients with hypertension. but it is a congenital disorder, and it is also seen in other disorders we have discussed. Blood supply is most important. You need to see the clinical features and then correlate with that. The anterior cerebral artery, the middle cerebral artery, the posterior cerebral artery, what are all the areas? The commonest site is the deep penetrating branches of the middle cerebral artery supplying the basal ganglia region. That is the commonest site of stroke, and what are all those clinical features? Head injury, coup and contra coup injury, whiplash injuries, injuries causing subdural hemorrhage in later age, old age, epidural hematoma, subdural hematoma. Dura is tightly attached to the bone, so epidural hematoma is always with a fracture. Subdural, later age group, shaking, usually fall in the house, but presenting with symptoms after few days to weeks. Subarachnoid hemorrhage, wherein the blood enters the sulci, is hypertension, atherosclerosis, secondary causes, not the trauma. So, subarachnoid hemorrhage appearance, and think of hypertension, barianeurysm, atherosclerosis. Hypertensive intracerebral hemorrhages, the commonest site 55% is putamen, but all of them together is hypertensive hemorrhages. The commonest site is this: atherosclerosis, hypertension, heart disease, atrial fibrillation. So, MCA stroke, depending on the size of the artery involved. The deeper branches, which is the commonest, is the basal ganglia, internal capsule, the classic hemiplegia. Now, left dominant hemisphere stroke, aphasia, right hemiparesis, difficulty reading. In 2 years exams it has come, this history. ACA stroke, foot and leg, impairment of gait, posterior cerebral memory deficits, visual deficits, hallucinations, and briefly infarct pathogenesis. Initially it is red neurons, then there is acute inflammation, then there is chronic and macrophages, foamy macrophages, but remember there is no further stage, no scarring, it is only empty cavity. Okay? So, only that part is missing than other healings. So, initially it is just the irregularity, hemorrhage. If it is obstructive, then it will be pale with pink punctate hemorrhages, then there is cavity formation and healing by just gliosis, big cavity. Okay? Microscopically just a cavity with glial cells at the periphery. AV malformations, congenital, GI tract, lungs, and the commonest is brain. It produces focal tuft of abnormal blood vessels, it can bleed. But hypertension stroke in this location, central pontine hemorrhage, do not think of any stroke. It is intracranial pressure increase, herniation of the brain. Week 4, degenerations, CNS degenerations. Alzheimer's the main and all others are minor. And to understand this clinical features, Broca's area you have to read cingulate and parahippocampal gyri, hippocampus. The degenerations, central degenerations affect this first. When it affects the whole brain, gradually spreading from this area, Broca's area, to the whole of brain, then it is typically Alzheimer's. When it affects individual systems, then it is Parkinson's, Huntington's, motor neuron disease, others. Secondary degeneration, infections, mad cow disease, prion disease, alcohol, B12. Myelin degenerations, multiple sclerosis. The major one, Alzheimer's. Total summary is loss of brain tissue with compensatory dilatation of ventricles and sulci. Microscopically, three major features: intracellular neurofibrillary tangles of tau protein, irregular network, and amyloid plaques outside, the two major. And then the third one is amyloid angiopathy, around the blood vessels deposition of amyloid and making the blood vessels thick, stiff and narrow. Okay. And these plaques are secondary to neuronal degeneration. So, there will be loss of these neuronal cells happening, and that happens, starts in the Broca's area but spreads to the whole of brain. So, I have summarized all about Alzheimer's in this one slide. Pick's disease is only, the difference is it is limited to frontal and temporal. Microscopically the same tau protein, but instead of irregular network it will be round body, known as Pick's body. Okay. Knife blade atrophy, and characteristically patients have aphasia or language dysfunction with preserved memory. So, very easy to differentiate clinically. We had a pathologist in Townsville Hospital some years ago. He was diagnosed with Pick's disease and he was retired from work, and then he had come back after recovery. So, that was an interesting clinical case, and he was a proper pathologist without any problem later. So, had complete recovery. Pathologists are special. Diffuse Lewy body disease. Diffuse Lewy body disease is bit difficult name, but remember it as Parkinson's plus Alzheimer's. That's all. It is Parkinson's plus Alzheimer's. So, there will be movement abnormalities and the dementia. Parkinson's, shaking palsy, reasonably common clinically. So, better to know. Appearance of the patient is the first diagnosis. Dopaminergic nerves, bradykinesia. Pathology is only loss of pigment in the substantia nigra in the brain stem. Microscopically loss of neuronal cells, pigmented neuronal cells. This is normal. This is Parkinson's, and they have Lewy bodies. Huntington's, selective degeneration of only the basal ganglia. Dementia, depression with jerking movements. Caudate and putamen only, that is striatal atrophy. Alcohol induced Wernicke's encephalopathy and Korsakoff psychosis. Two of them, just two lines probably, just what are the features. Wernicke's encephalopathy, there is bleeding in the mammillary bodies and degeneration in the strata. Vitamin deficiency and neuropathy. Commonest is only B12 deficiency. B1, B2, B6 and B12. Commonest is B12, but in alcohol it is actually due to B1, Wernicke's and Korsakoff syndrome. It is not really the toxic effects of alcohol, but it is the associated B1 deficiency which contributes. Multiple sclerosis is an autoimmune disorder, young females, genetic environment plus autoantibody to the myelin. So, destruction of the myelin in the white matter, and usually the inflammation patch is next to the ventricle. So, paraventricular irregular patches of inflammation. So, microscopically it will be really inflammation with destruction of the myelin, and on a MRI it shows up as inflammatory plaques surrounding the ventricles. So, progressive, with every attack there is some improvement, but with some residual paralysis, usually movement and eye movement involvement. CSF shows increased IgG because it is a autoimmune. microscopically just loss of myelin, and it is more around the blood vessels. Myelin has been stained with the blue stain here, and if we give these pictures in the exam, we will mention it has been stained for myelin. And what you have to identify is loss of myelin around the blood vessels, because that is where the antibodies are coming, and these patches appear around the blood vessels. Amyotropic lateral sclerosis is the commonest type of motor neuron disease. So, it is a subgroup. There are motor neuron diseases, as the name, it is motor neuron disease. Amyotropic lateral sclerosis is when there is loss of myelin around on both the sides of the posterior part of the spinal column. Amyotropic lateral sclerosis. Progressive muscular dystrophy, muscular atrophy, primary lateral sclerosis, progressive bulbar palsy, ninth nerve. There are different types of motor neuron disease. I just put some example highlighting the features of different types of common dementias. Okay. Week 5, the next stage, meningitis and tumors, brain tumors and meningitis. So, we put the different scenarios for a meningitis. Important is fever, headache, neck stiffness, Brudzinski sign, Kernick sign, CSF findings. Tumor, crescendo, gradually increasing headache, morning more, then later presenting with seizures and localizing signs. Epilepsy, negative signs mainly, recurrence and familial. Infections, meningitis the commonest, but meningoencephalitis when it is combined. Infection of the dura is very rare, only secondary to fractures. Arachnoid inflammation is the commonest, known as leptomeningitis, and that is due to bacterial, viral, fungal, tuberculous. Chemical carcinomas and drugs can also cause meningitis. So, just know the names, but important is bacterial, only read. And the inflammation is limited to the arachnoid only, it does not involve the brain or the dura mater. So, it is known as leptomeningitis. Encephalitis is when the infection is within the brain, that is an abscess with meningitis. Okay. So, septic meningitis, neonates E. coli, Neisseria meningitidis, adults, adolescents and adult streptococcus. All the features you all know. Gross appearance is pus on the surface, microscopically acute inflammatory cells, neutrophils in the leptomeninges, neutrophils. And in a high power view and a gram stain, you can see the gram positive diplococci, streptococci, or gram negative diplococci if it is meningitis. Okay. So, appearance normal, septic, gram positive, diplococci. Viral meningitis, the only word you need to know is perivascular lymphocytic cuffing, perivascular lymphocyte cuffs and microglial nodules. The microglial nodules are difficult to differentiate, but only perivascular cuffing is more important. A lot of viruses, many different types and many clinical presentations. So, CSF examination, normal, septic, viral and tuberculosis. I am sure you all know very well. Now, brain tumors, yes. Here it is viral meningitis, most of them are with viral encephalitis as well. But in case of virus, it's most commonly it is both meningoencephalitis. So, you are right, it should be, this should be encephalitis part of the meninges. meningitis. But in meningitis it would be just lymphocytes in the meninges. He catches me even at the end of the year. Good. Okay, tumors. Meningiomas, commonest meningiomas and glioblastoma. Now remember, glioblastoma is not a separate entity, it is a type of astrocytoma. So high grade astrocytoma is also known as glioblastoma. So astrocytomas are the commonest tumors both in adults and children, and other than astrocytoma the only other common tumor is meningioma. All other tumors are rare. So only childhood astrocytoma and medulloblastoma in children, glioblastoma and meningioma in adults. Okay. So in adults it is upper, in children it is lower. Meningioma in the meninges, along the venous sinuses. Origin is from the arachnoid sinuses. Sorry, is it arachnoid sinus? No, arachnoid sinus is in the ventricles. I am looking at him, he is smiling. Not going to help. It is from the arachnoid granulations within the venous sinus, that is the meningiomas. Choroid plexus is in the ventricles. Okay, that does not give rise to meningiomas. So meningiomas along the venous sinuses, they produce dense hard tumor whorls of fibrous tissue with calcifications, plenty of calcified psammoma bodies, and they are usually at the periphery. They are benign tumors. Very rarely they can be aggressive, but usually they are benign tumors. They just compress, and most commonly they don't produce any symptoms. Only when they are rapidly growing, occasionally they produce the typical features of brain tumor. Now astrocytomas, the tumors of astrocytes, many different types, but the high grade one is known as glioblastoma multiforme. Just to remember, usually they are graded as grade 1, 2, 3, 4, and grade 4 is also known as glioblastoma. Now gliomas, I have put all different types together, commonest, low to high grade. When it is low grade, it does not produce any peripheral enhancement. Slow growing tumor, not much of inflammation, not much of any necrosis. Only it shows as a tumor on an MRI, but it has no hyperdensity, no increased inflammation, but there is destruction, you can see. So a low grade astrocytoma. A high grade astrocytoma shows prominent peripheral hypervascularity there, that is why it shows positive, and with inflammation and edema surrounding the tumor. So that is a high grade, that is a low grade. Okay. A low grade appears as just diffuse swelling, does not look like any benign tumor, there is no capsule. Whereas high grade produces that characteristic varied morphology, hemorrhages, necrosis, irregular coloring, and that is why it is called multiforme, multiple formats. Okay, glioblastoma. I have not shown the microscopy of low grade, only you have to remember is the high grade one. You just have to know only that in glioblastoma there is necrosis with peripheral palisading. The cells appear like lining up the areas of necrosis. That is all you have to remember microscopically. Herniations, increased intracranial pressure, subfalcine, transtentorial, tonsillar, and what are all the clinical features, that is more important. Why pupils dilate in increased intracranial tension, a lot of basic things, so you know better than me. Week 6, pyrexia of unknown origin. Clinically it was that, but we are covering all fevers, specifically for tropical. So, I have added this word, but next year we should add tropical infections. Lot of infections, tropical infections is CMV, HIV, hepatitis B, herpes, so many, but important we are covering is Ross River, dengue, lepto and Q fever. So, I have just given briefly about these. Major arboviruses are the same, except that these are the viruses transmitted by insects, that is all the difference. So, Ross River fever, arthritis, fatigue, headache, lymph node. Dengue fever, primary, secondary phases, severe abdominal pain, fever like a flu, but the secondary phase of hemorrhage and organ failure is more important. Melioidosis, Burkholderia pseudomeli, bacteremia, skin ulcers, and most important is lung infection looks like tuberculosis, apical lobe with cavity formation. Okay, apical lobe with cavity formation. Wet seasons, rainy seasons, and North Queensland, and our Ross River is the name for this. Leptospirosis, jaundice, fever, hemorrhage, renal involvement, Wales disease. Again, this is a biphasic disease. Most of these tropical infections biphasic. The first phase is actual infection presenting like a flu, some with arthritis, some with diarrhea, some with muscle pains, and later going on to immune phase where they develop antibodies and they start causing internal damage more. Q fever, Q is not for Queensland, it is query, means I did not know. So, query fever, although it was found out in Brisbane. Coxiella burnetii, acute and chronic phase, muscle joints, again this is biphasic, acute and chronic. And important you should know is vaccine. North Queensland, most people working in this, they have to have vaccines. Pre-vaccine testing is an important procedure, unlike other vaccines. The secondary phase is the most, chronic phase is the most dangerous. The primary phase may heal even without treatment. Hepatitis, endocarditis, pneumonia can be very serious. Pneumonia can occur even in acute phase. Just a brief, chronic fatigue syndrome in many chronic viral infections, herpes, enterovirus, EBV, RRV, Ross River virus, Q fever, Lyme, mycoplasma, so many. Reduced lymphocytes, decreased immunoglobulins, and altered immune response to virus are seen in this chronic fatigue syndrome. Last week, musculoskeletal fracture was the main, and a brief mention of sarcomas, malignancy other than the carcinomas. The fracture healing I have summarized all in one here: normal structure of the bone, compact bone, cancellous bone. A fracture in the first day is hemorrhage, inflammation up to 1 week, 1 to 3 weeks is soft callus, after 6 weeks is, up to 6 weeks is hard callus, deposition of bone when it is seen on the X-ray, after 8 weeks is remodeling. In a typical healthy normal adult, the times can vary depending on other risk factors. So, complications we have already discussed, short term complications and long term complications. Paget's disease is an unknown etiology, excess breakdown and excess healing, that is all, fracture everywhere. It can occur in one bone or multiple bones, and it can lead to osteosarcoma as a complication. That is the skull image and that is the long bone. The bowing, thickening, and the bone is thick but very soft. Vitamin D deficiency, the difference between the rickets in children and osteomalacia, ricketic rosary, why it is the thickening of the growing ends because of excess deposition of cartilage. The tumors, there are many different tumors, but remember only the commonest ones. Osteosarcoma is the commonest sarcoma in a clinical practice. Other sarcomas are fibrosarcoma, malignant fibrohistiocytoma, liposarcoma, rhabdomyosarcoma. Many other tissues can give, but remember only osteosarcoma, bone malignancy is the commonest. Benign tumors are reactive conditions is Paget's disease, osteochondroma, chondroblastoma. Just these are the reasonably common benign tumors. Now osteosarcoma, one summary here, ends of the long bone affects only the metaphysis and usually spares the epiphysis. Upper end of the humerus, lower end of the femur or upper end of the tibia, means around the joint, shoulder joint and around the knee, the commonest location. Very young age primary tumors, but secondary osteosarcomas can occur in later age. Knee and shoulder, it is usually painful unlike other carcinomas. It can result in fracture and present as just a fracture, non-healing. My X-ray, there is excess deposition, granular deposition of the bone around the metaphysis. Microscopically, plenty of lacy osteoid, irregular cells, lacy osteoid. That is all, two features microscopically. Just a passing mention, names only. Myositis is inflammation, infections, viral, autoimmune. Dystrophy is irregular structure, usually congenital, usually but not necessarily. Myopathy, myopathy is usually non-inflammatory abnormalities, toxic or congenital, and tumors are known as rhabdomyoma or rhabdomyosarcoma. Okay. In a clinical situation, commonest is myositis, inflammation. All autoimmune disorders, traumas, myositis. Muscular dystrophies, I have just put few. Muscular dystrophy. Dystrophin, it is an inherited defective, appears irregular bluish muscle fibers. That is a normal muscle fiber with a nucleus at the periphery, and these are the dystrophic with few inflammatory cells and fibrosis. When it occurs in young age, more common, it is known as Duchenne, and Becker is at the later age. And usually children, they climb on themselves taking support of their legs because their muscles are weak. Okay? And that is the classic presentation. At a later age, this is the presentation. That is it, term 3. Now afternoon we will cover term 2 and term 1, how much possible. I have not yet prepared, so I have to prepare still.